Hi, everybody. My name is Alex Borzak. I'm a Doctor of Nurse Practice student for Widener University, and I'm going to be talking today about transitions of care programs, a little bit about what they are, some ways that providers are able to work within or develop a transitions of care program, how one is developed from scratch, and then also look at different issues as far as like risk identification, stratification, and how that all ties into care planning for your individual patient. So this is actually going to be broken down into 4 modules covering all of those different topics. For this presentation, though, we are going to look at just the definition of what care transitions of care programs are. And really what we're looking at here is how to optimize this process of caring for these individuals while allowing and ensuring that their medical information is fully available at any time during this care continuum for the patient. And to be able to do that, the evaluation of transitions of care, and one of the big focuses of transitions of care, is looking at those vulnerable points where information is most likely to be missed. And if you actually look at a graph of where a patient travels along from facility to admission through the hospital and discharge and back to their home primary care office, there are a lot of different points along the way where information is very likely to be missed. And this is not a linear process. This can go the other direction as well. It can go either from the hospital to the primary care provider, or even from the primary care provider to the hospital, for example. So like the hospitalist might not be able to read or look at the progress notes from the patient's primary care physician if they're out of network, or even in some cases if they are in network. And that can inhibit care while in the hospital because they don't understand the context of this admission within the full continuum of that patient's medical problems. And then also you get transfer points from primary care provider to specialist, skilled nursing facility or rehab to primary care. It can be between primary care physicians, especially if you have a patient that is changing practices or changing providers within the same practice, or even you have a pediatric patient who's graduating from a pediatrician and now needs to start seeing a family medicine doc or an internal medicine specialist. And then also, of course, primary care to your care management team as well is a very important transition of getting that information from that initial visit to your care management team so that they have an idea of what needs to be done for this patient. There are 2 different lines of thoughts when it comes to transitions of care programs. The first one is done in 2010 by the National Transitions of Care Commission, or the NTOC. And they came up with the 7 essentials of what needs to be included or what needs to be considered when developing or evaluating a transitions of care program, or just general transitions of care going from one facility, one setting to another setting or facility. And again, this is where the big focus of having to evaluate those points of transfer come into play. Also, some other considerations within the 7 essentials is making sure that you have information, first of all, have information to be transferred, and that the information is going to be useful to those that are receiving it so that they can understand the context of why this patient is being sent to this person or this facility or this office and what the goals of care are. So this is very much an inter-facility focus. In 2019, the American Case Management Association came along and developed these 5 standards of a transitions of care program. And their focus was more so within the primary care office rather than from primary care office to another facility or another provider. And what they looked at is looking and seeing that the time spent with the patient in the office was productive at developing a plan of care, at identifying barriers, at creating flows of communication and compiling the information that is readable and that is necessary in order for the care to continue, for that patient to decrease their chances of being readmitted to the hospital. Additionally, these programs cut down and really focus and identify target populations of patients that need or have a higher likelihood of needing these types of services. These patients or these services, this program is meant to decrease hospital admissions and ER overutilization. So that's going to be two of the biggest populations that you're going to be utilizing for this program: is hospital discharges and people that have had a visit in the emergency department. But the other population that needs to be considered as well are those patients that are new to the practice or are reestablishing care to the same practice that they were taken off of the patient rolls for, because they also need assistance and need to have barriers identified at that time as well, until everything else gets up and running on the outpatient side. They're very vulnerable at having to go to the emergency department for something that could have been done in the primary care or outpatient setting. So therefore, what we do then is take these target populations and we break it down even further and try and identify these patients that have a high risk of either rehospitalization, repeat ED utilization for primary care problems, barriers that prohibit them from seeking or receiving medical care, particularly in the outpatient setting. So we want to address those, or at least, if not solve them, at least reduce them to a size or to a degree that the client is able to overcome them and be able to receive care in the outpatient setting. And also those patients that have complex care needs as well. Interestingly, here it's worthy to note that these patients don't necessarily need to have have all four of these different points to be included in a transitions of care program. It could be one, it could be two, it could be all four, but it doesn't necessarily have to be. One of the things that a transitions of care program looks at is not necessarily comorbidities necessarily, but it looks at the entire picture as a whole to try and predict whether or not this patient has a potential for rehospitalization or increased reutilization of the emergency department, that kind of thing, along with assessment of barriers. This is a generalized process of how the transitions of care program would work. And you can see this actually starts even before the patient is discharged from the hospital. They're given a follow-up appointment date and time with their clinic, with their primary care visit, with their primary care office before they even leave the hospital. After that, within 1 or 2 days after they do leave the hospital, their clinic calls them, touches base with them, make sure that they have all of the information that they need. And then at this point, they're also doing a risk stratification to decide and determine what level of services this patient may need to keep them out of the hospital. And from there, that's going to turn into how the goal setting, what kind of goals are going to be set, what kind of resources are going to be utilized. And then 30 days after discharge, they're going to reevaluate, because we're really focusing in on this no readmissions within 30 days of discharge time period. So 20 days, 28 through 30, we're going to reevaluate this patient and see, do they still need to maintain this level of intensity of services, or can they be changed, or can they be taken away completely? Another reason why we're concerned and why we want to start utilizing transitions of care programs is because of the resources that are available. They're becoming scarcer and scarcer the more complex our patients' needs become. Also, in general, the health system is becoming more and more relied upon to manage critically ill patients, and not even addressing the pandemic or anything of that nature. Just in general, even before this, emergency departments are becoming busier with patients that are sicker and require higher complexity of emergent care. And this is due to the ability to be able to treat patients with complex problems in an outpatient setting more so than what has been done in the past. And that trend is going to continue. So we're seeing this paradigm shift away from emergency departments being able to even think about being that safety net for patients that have needs that could be addressed through primary care, but have barriers that prohibit them from obtaining this care reliably in an outpatient setting. The cost of these transitions of care programs is intense. There's intense resource use, but is short term. These programs are intended to shore the patient up to decrease inappropriate utilization. And it's a big upfront cost, but later on down the road, that cost is paid back just in cost avoidance. And then also, in order to best utilize resources, you need to identify and be proactive in initiating outpatient support for these patients as well, so that they don't go back to the emergency department or continue to utilize services that are inappropriate for them at this particular stage of their disease process. So again, this is goal-directed care intended to direct patient utilization towards more appropriate resources, predominantly in the outpatient setting. And who requires what level of intervention. Not every patient is going to need the same level of intervention as another patient is. So this is highly individualized care that these patients are receiving. The cost of these programs, again, like I mentioned before, it's increased. Their short-term costs, however, they lead to long-term cost savings because they're being directed into more appropriate preventative services. They're also not just pigeonholing them into a certain care pathway, but also these programs seek to change patient behavior when they are seeking care, because we are identifying and attempting to address these barriers that are prohibiting them from obtaining this care in the first place. But also we're directing them and we're changing that behavior where it might be a knee-jerk reaction to go to the ER if they need something to be taken care of, and relearning them and reteaching them to seek care in an outpatient setting first before going to the emergency department. Unless, of course, they absolutely need to go to the emergency department, then by all means they need to go. But for complaints that can be dealt with in an outpatient setting, they need to be addressed in an outpatient setting first. Furthermore, it comes back the process, the overall process focus, particularly of the NTOC 7 essentials, is this focus is on decreasing the inefficiency within those processes as well. And this is part of the long-term cost savings, because you're making your process in general as a whole more efficient. You're appropriately utilizing resources. And then also, even though you're not going to gain a lot of benefit from this, there is some financial benefit, there is some financial reimbursement that you can bill for certain TCM services. So this does open up another billing avenue for practices for complex patient education and other care management services that you're going to be providing to these patients as well. This concludes the initial presentation, just giving you a background and definition of what transitions of care programs are and the goals of the transitions of care program. What you can do now is I invite you to pick up your smartphone, open up the camera app, and hold it up to the QR code. Click on the link that pops up and complete the short survey. That gives me some feedback on the quality of this presentation, and also gives me an idea of how much of the information was beneficial to you. Thank you very much for your time, and I really appreciate the feedback. Thank you, guys.